Thanks.
Okay. So this is just a reminder of the working group leadership, myself, Jazz and Robin, with Melanie, our fellow. We've got two patient research partners, Birta Peterson and Martin Kennedy. Martin's definitely here. I'm not sure if Birta has made it yet.
No. Birta just texted me she can't enter the meeting, so yeah.
Can someone let her in, or can you send her a new link?
Yeah, we'll do it. I'll do it. I'll take care of it.
So this is our working group membership. So what we thought we'd do in this session today is start with just the patient voice. We'll hear from Martin. We can hear from Birta later if she can join, and then we'll run through where we're up to date. So Martin, can I hand over to you?
Thanks, Lisa. Yeah, it's a real pleasure to be here. I guess a few words about me. The first thing is, as I said, I'm a colleague of Lisa's, so I'm a genetics researcher who works on complex disease. So I'm engaged in a very interesting N=1 trial of my own condition. I don't know much about gout, I have to say, or a little bit. My first awareness that I had gout was about 13 years ago, and I got a very severe ankle flare, which incapacitated me. And thereafter I had minor flares over a period of a few years, but I didn't formally get my urates measured until 2010, about 3 years after my first flare, and that was as part of a clinical trial. Being based in a clinical school, of course, you end up in various trials, and thereafter I've been involved in several of Lisa's trials. So I guess as a patient goes, I'm a little unusual and probably a little fortunate in that, you know, I've had access to really good expertise and care through Lisa and her clinical trials. And I've also had my urate measured at least 15 times over the last decade or so. So it probably shouldn't have been a surprise that I got gout. My 92-year-old father has gout and is on allopurinol, and my 91-year-old mother also has had a bit of gout. I have an older brother who has gout, and I have 3 other brothers who don't have gout, one of whom I think may have just enrolled in a trial, which I'm guessing that Nicola is probably running. And his urate turns out to be the same as mine was, about 0.5 millimoles per litre. And really, obviously don't want to take up too much time, but I just thought I'd make 2 comments. Well, the first I've already made, which is really, I guess as patients go, I'm a little unusual and a little fortunate being based in medical school. So my care has primarily been through Lisa's clinical trials rather than via a GP. But the second comment really is that I can't pass judgment on whether serum urate is a good proxy or surrogate marker. I can say it's been incredibly motivating to be able to just sort of watch my urate levels, especially as I started on allopurinol, and watch them come down. Incredibly motivating and sort of reinforcing to see them come down to within the normal range. Anyway, I won't say more at this stage, but really happy to be here, and thanks for making time for me.
Thanks very much, Martin. Melanie, has Birta made it yet?
No, but she's sent me a text with what she wanted to say, so maybe I should read her perspective.
Okay.
Yes, good. She writes that, my name is Birta Peterson, I'm 67 years old. I've been living with gout for several years. I've been a patient at Melanie since spring 2017. At that time, I had pain in my right foot, my fingers, 3 to 5 flares a year, swelling of foot and fingers, and tophi on the fingers. It had a great impact on my quality of life. Every time I was traveling, leaving the house, I was afraid of getting a flare. Now I have had my latest flare in 2018. I have no pain, no swelling in my foot and fingers, and my tophi has almost disappeared. I have a high quality of life, and I can do what I want, and I'm never afraid of a flare. My serum urate is normal, and I think it's nice to know and to follow the serum urate and connect the results to my well-being.
Great, thanks very much. So we thought we'd just run quickly through where we've come from. So just to remind people that this work has been going on for quite a while. In OMERACT 2008, serum urate was endorsed as a core outcome domain in chronic gout with 83% in agreement. And you'll also note that flare of gout was also endorsed as a core outcome domain. In 2010 OMERACT meeting, serum urate, we started looking at serum urate as a biomarker in gout. And at that meeting, serum urate was accepted as having fulfilled the OMERACT filter by 78% of voters. However, consensus was not obtained regarding its use as a soluble biomarker. The key criterion of association of the biomarker with outcomes was not agreed upon, and it was felt that the appropriate choice of endpoint must be linked to its clinical importance to the individual with the disorder and its temporal relationship to the intervention. So therefore, appropriate outcomes would include flares, reduction in tophi, and other patient-reported outcomes. So at this point, what I'll do is hand over to Robin to talk about the difference between biomarkers and surrogate endpoints. Robin.
Thanks, Lisa, and thanks for having me. This is clearly, oh, sorry, yeah, fine. You can switch it. The idea here is that I'm supposed to just briefly introduce to you why we have now a new term in OMERACT, since most of you, I'm sure, would have known about biomarkers and endorsement of biomarkers even. This is actually in front of us, the first paper I ever co-authored with OMERACT, a general framework for what it takes to be a soluble biomarker that we endorse at OMERACT. Yes, please. So the thing I did is I looked it up at I looked up what the biomarker is from various sources, and technically speaking, a biomarker is a physiological marker of some sort, could also be imaging, which is a measurable indicator of some biological state of or condition, and we use them quantitatively to examine biological or pathophysiological processes, and eventually we also use them for pharmacological responses to a therapeutic intervention. However, we only use them at the very early phase officially if you go to the authorities like the FDA in the States and EMA in Europe. Yes, please. On the other hand, coming back to what our patient partners just informed us, is there's something completely different from biomarkers. We call those patient-important outcomes, not to confuse directly with patient-reported, but patient-important are outcomes that are important to patients. And in the literature out there, medical literature, is typically argued that it's health-related quality of life morbid endpoints, such as hospitalization, bone fractures, stroke, myocardial infarction, or death. And I add, for the purpose of this SIG, also gout flare attacks from what we just heard from our patients. Yes, please. Looking it up in the dictionaries, I looked it up in Cambridge Dictionary. What's actually now then the new thing about surrogate? Surrogate means a replacement. According to the dictionary, it says replacing someone else or used instead of something else. And they have an example. Yes, please, Lisa. The example that's completely beyond rheumatology is, because she had no children of her own, her friend's son became a kind of surrogate child to her. That's in terms of native English. Yes, please, Lisa. Then when we look into the more technical literature, there's a paper, I'm just about to say a famous paper from the JAMA back in 1999 from the great working group of McMaster and colleagues of us at OMERACT that defined a surrogate endpoint as a substitute outcome, being that they are not in themselves important to patients, but are supposed to be causally associated with outcomes that are important to patients. And yes, Lisa? What I'm trying to get at here is actually what we in statistics call a causal model now. We know when we give a drug and you apparently effective intervention to patients with gout, we would, yes please, we would hope that it is able to lead a large proportion of patients into serum urate target. Yes, Lisa? And from that, we would also expect that it is able, in terms of the outcome, to reduce or create no flares at all. But the really important thing to our group is actually this arrow down here, which is that we imply that there's a causal arrow that leads us to say that getting patients into serum urate target, that will also create us to have no flares, or at least a very low frequency of flares. Yes, please. So the technical thing that happens now is we actually, with this working group, are trying to convince people from data, from evidence, that the indirect arrow going from the treatment is not important, that it goes directly through the serum urate target, and there's not an indirect effect from the intervention. Sorry for the technicalities. Yes, please. So what this really gives to us now as a working group in this SIG for this evening in Europe is that what is then the bridging from biomarkers to surrogates to patient-important outcomes. Yes, please. A good biomarker good biomarkers are pathophysiological outcomes that clinicians consider important, but they cannot be communicated clearly to patients, i.e. they do not substitute for patient-important outcomes. I dare to say that biomarkers are almost per definition not ready for prime time. Following that, and this is why we're here today, a valid surrogate endpoint would be a biomarker or physical sign that can substitute for a clinically meaningful endpoint that measures directly how a patient feels, functions, or survives. Yes? So examples for prime time surrogates, we get that question a lot for good reasons. So what are really successful biomarkers that turned into being surrogates? We usually hear about bone mineral density, we hear about blood pressure, and we hear about the low density liver, or rather LDL cholesterol, as being important biomarkers. They're actually so successful that they got their own conditions, to be honest. Yes, please. So what that brings to our group tonight or today is actually that we want to show the following from the framework from the great working group and McMaster and blah blah elsewhere, how to move from a biomarker to surrogate outcome. Yes, please, Lisa. So what we'll be trying to take you through is, for the Gout working group's perspective, we need to show that from cohort studies, there need to be a strong, independent, consistent association between the biomarker, potential surrogate, and the clinical patient-important outcome that the biomarker could potentially replace. But that's only, let's say, silver standard. The gold standard would then be achieved if there's evidence from randomized trials in the same drug class, and as you'll hear today, for example, from allopurinol trials, that improvement in the surrogate endpoint has consistently led to improvement in the target outcome, such as less gout flares. And then the platinum standard, with my words, would be even more RCT data, for example, in the meta-analysis or doing exemplified analyses, as you'll hear today. Is there evidence from randomized trials in other drug classes that could, for example, be also having trial data on febuxostat, that improvement in the surrogate endpoint has consistently also led to an improvement in the target outcome? Thank you.
Thanks, Robin. So I'll hand over to Melanie, our fellow, now to take us through this section.
Yes, thank you very much. So the question is, can we show a relationship between serum urate and gout flares? Yes, please. So we did a systematic review and meta-regression analysis that was published in 2018. Yes, please. And the conclusion was that the meta-regression did not support any statistically significant association between the difference in proportions of individuals who achieve serum urate under 6 mg per deciliter and the observed flare risk ratio. And regarding serum urate as a surrogate, we used the biomarker surrogate evaluation scheme 3, and serum urate did not reach the desired level of evidence to be considered a surrogate according to this method. This was due to a lack of statistical evidence from the RCTs. Yes, please. So why could we not see a relationship? Yes, please. Well, there was a lot of variability in reporting. Serum urate and gout flares are inconsistently reported in clinical gout trials. And as Lisa showed in a previous slide, serum urate and gout flares are OMERACT core outcome domains, but how to measure and report is not specified. Another thing to consider is that when initiating urate lowering therapy, you have a time lag between achieving target urate and flare cessation. So maybe inadequate trial duration is also an issue. So we address this in a separate paper that is on top here. And Lisa?
Thanks, Melanie. So the next step, given that we couldn't show it with the, the data presented in the literature, was to get individual patient data. And so this has been our current approach to IPD analysis. And I'll just take you through this. So this is looking at a 24-month clinical trial. So we have used the first 6 months of that clinical trial as the run-in period, where patients might get to target urate. Then we used period 6 to 12 as the sustained period, and we've looked at the serum urates, the mean serum urate during this period, and then we've looked at the flares during the second 12-month period. At month 12, we have randomized the individuals to those who achieved target serum urate during this 6 to 12-month period and those who did not. And that's how we've done the comparator. So we've had access to 2 data sets, and I'll take you through this data. So the first data set we had access to was a New Zealand data set, which was from the allopurinol dose escalation trial. As you may recall, this was 183 patients in 2 years. There's some important things to remember about this trial, is not everybody was dose escalated during year 1. A number of patients were, at least half the patients were only dose escalated during the second half of that study. And what we looked at then was the gout, the number of patients who had at least 1 flare in the second year, or the mean number of flares. So you can see here, this is the people who were at target, had a mean target urate at months 6, 9, and 12 of less than 6 and greater than 6. You can see that still the majority of, or a third of patients at target had flares, compared to 40% who were not at target, and this didn't reach statistical significance, and nor did the number of flares. And we could talk at length about why that might be in the New Zealand data, but I think there are definitely trial-specific reasons for that. We then got access to the Nottingham data, thanks to Mike Doherty and Abhishek. And you'll recall this was the 2-year study where they looked at nurse-led versus GP usual-led care. So everybody was dose escalated from the outset of this trial. We had 290 of the roughly 500 people who achieved mean target urate of less than 6 in the 6 to 12-month period versus 227 who did not. And with this larger group who were all dose escalated from the start, I think we can clearly start to see a relationship where the number of people having a gout flare in the subsequent 12 months was 25% in those at target versus 65% in those not at target. And the mean number of flares was significantly less, with 0.63 in those at target compared to 2.41 in those not at target. And both of these reached statistical significance with a p-value of less than 0.001. We also looked at TOFUS regression with the Nottingham data again. You can see for those without a TOFUS at baseline, the mean for those who had a target, were at above target urate for the 6, 12 and 9 months, about 7% developed a TOFUS compared to only 0.4% of those who were below target. And for those individuals who had a TOFUS at baseline, those who were above target, only 40% lost the TOFUS compared to 85% of those who were at target in that preceding 6-month period. So with that, we can open for initial discussion. We do have 2 questions that we want to vote on, but we might open it up for discussion at this point. Shall I put up the first question maybe, and that will help guide us? So question 1 is, do we think it's important to distinguish biomarkers from surrogate markers? So before we vote, we will have some discussion. Nicola, would you like to open the discussion?
Sure. So I guess I'm sort of interested in the kind of context of this and where we might use the biomarker, surrogate marker, particularly in the context of the current regulatory system, where, at least for most jurisdictions, it seems that serum urate lowering is sufficient for approvals, at least what we've seen with many of the approved drugs in the last, I guess, decade or so. Both febuxostat and lesinurad were approved based on essentially serum urate reduction. So it seems that the regulators already see that or accept that serum urate is a biomarker surrogate, some kind of spectrum of that. So I guess it would be useful to sort of understand a little bit more about, or discuss the sort of applicability of this, and what the practical implications of this are.
If I can support Nicola, or just respond, although I'm biased, one of the issues would be, if we don't call it a surrogate, we'll just be put behind the row, so to speak, because the big journals, the authorities, they tend to claim that needs to be surrogates in order to be important to them. So there's a semantic that's important for authorities.
I think the other thing is, I think there's two comments I'd make. One is, I think we have started to see pushback from journals about using serum urate and not using a clinically important outcome measure such as flares. And I might be shot down in flames here, but I think the heyday of new gout drugs may well have passed. And so this is going to affect us as, I'm not sure we're going to have many big drug company trials coming like we've had in the last decade. So for those of us doing clinical research, we're not going to be able to fund trials using flares as an outcome if that's what journals are going to want. I think the second thing is, as most people here will be aware with the ACP, they certainly pushed back quite hard against using serum urate, and they felt there was no data to support this relationship. So I think that it will give us evidence to push back against that.
Thanks. Ken,
I comment?
Ken?
Yeah, just
to comment.
Sorry.
I think there's a really interesting issue here that relates to a lot of different factors. First of all, I'd be interested, Robin, in your the analysis that you presented. Were peglotic case studies included in the meta-regression? Because that's the most compelling clinical trial data. The other issue that I think we need to take into context is that the outcome is not a good outcome in the context of clinical trials. Our ability to measure flares is limited both by the definition of what a flare is, and probably more importantly by the inability to accurately capture it accurately and reliably in clinical trials. So you have a very noisy signal, and so this is problematic in trying to make the association. And so I think it's a pretty, in my view, a pretty classic example of the absence of evidence is not evidence of absence. And the example used of BMD and osteoporosis is really one worth considering, because the biologic association between BMD and fractures is remarkably weaker than the biologic association in the causal pathway between serum urate and flares. And if you wanted to have a better example of sort of biologic plausibility and the causal pathway, it would be hemoglobin A1C and diabetic complications, where that's probably like serum urate explains a greater degree of the variability in the outcome than does BMD and fractures. So I would question if BMD has been accepted as a surrogate in osteoporosis, I think based on the biology, which I think also should be considered in thinking about the biological plausibility, part of the argument for causality, is much stronger with serum urate and flares. So we have a mix of a measurement issue, namely a very noisy signal, and less biologic plausibility for other so-called surrogates that you've alluded to in your discussion, compared with serum urate and flares.
Can I turn it around just to say, can you imagine trying to address gout in any meaningful way without addressing serum urate? You could address flares all right by having somebody take anakinra forever, possibly, but I think lowering serum urate over a sustained period of time is essential for achieving the ultimate aim of reduced flares. It's just the duration of time is the problem, isn't it?
Good points, and I'm pretty sure we had pegloticase in our meta-analysis can, but we can look it up, as you saw it is published. But really what Melanie was also referring to, that one of the issues is if it takes X time to get into target with the serum urate, it'll probably take X plus something extra to be able to get the benefit as a patient.
Yeah.
And that was actually the reporting issue that Melanie struggled with when extracting data. So that's why we decided to a large extent, at least said, to go one step back and now do IPD, meaning individual participant data, just kind of like so we're tweaking the original RCT designs, Ken, now to ask new causal questions by proxy, of course.
I mean, I think all those points are valid, and we you know, I think we're all in agreement with that. Jess?
Yeah, so I think this also brings up the issue that Robin and Ken and others have alluded to, which is we pretty much need for every RCT of a urate lowering agent now, ongoing now, or being planned for the future, to push for and have our pharma colleagues and industry think of long-term extension phases, even if the RCT cannot go on for too long because of cost issues, to simply not only address this issue that data could help further solidify the surrogacy of serum urate and further strengthen its biomarker status, but also to look at some other additional outcomes like productivity and absenteeism, presenteeism, functional outcomes, objective and others, which obviously can be captured between the month 12 and 24 and month 12 and month 36, rather than just within 6 months short trial, which is nice for a serum urate outcome, but does not help further connect the dots for gout outcomes. So if we can push as investigators to our pharma colleagues to think of long-term extension phases, which are a little bit more affordable than the randomized phases that go on to 24 and 36 months, I think it could help clarify things in the future.
So are there any other comments around that issue, or do we want to vote on that question?
I just want to make one other comment, Lisa, that goes to Ken's comment, which is that the patient outcome of gout flares is noisy. And Ken and Ralph and Will and others sort of led the effort with international team to validate a gout flare definition, which does not require a lot of components other than, you know, patients think it's flare. It's just three other components that can be captured in less than 60 seconds from a patient on the phone or in the clinic. Also sort of having those components of gout flare validated definition. There's been a subsequent international effort with many people here in the group having led and contributed to it. If those components of flare can also get in the trial, as they don't add significant burden or feasibility challenges, that can also address the issue of a noisy signal for a very important outcome that can clarify this association. But I'd be interested in what others think.
Lisa, I have a comment, not directly related to Jazz's question, but just an observation. I wondered whether you'd like to comment, or Robin would like to comment on the fact that the two RCT data sources for the second study were not were strategy studies, really, weren't they? They weren't comparing one drug with another, but how to use a
You're right.
how to use
It's
the
a
same
holistic-
drug.
Yeah, you're right.
And I wonder whether that does that have any kind of implications for the framework that you originally proposed, Robin, in your first talk, where you were much more talking about classes of drugs, etc.
Yeah, I guess you're right but I think I'm just putting some fuzziness on top of the whole thing now, since we are adjusting for the original randomization like you would do for confounder. So in this design, we actually consider the original randomization as being a confounder because it fulfills the criteria for a potential confounding factor. But I guess when we get to write these papers, that will be potentially a struggle whether it's nurse-led or it's simply the allopurinol prescribed by rheumatologists. But I'll let rheumatologists respond to that, or patient.
I agree, but most of the trials have got some sort of allopurinol dose escalation, and there's been challenges accessing any data from any other source. So this is the data that we're going to have. There is not going to be any other data.
Maybe, Lisa, before we quote unquote wrote in the first question, I would just like to advertise before answering. I think that if the reason we suggest this as a question is because biomarkers per se are nice to have, but if we are able to promote these discussions into surrogacy, I think we'll have a need to have argument. And since we are a biased crowd here of rheumatologists and patients who understand serum urate value, I argue for that is a reasonable consideration, whether it's semantics or not.
Lisa, could I ask a question? It's Dorcas.
Mm-hmm. Sure.
So on a very practical level, the answer to this question would be, the FDA sort of clearly has a framework for how it defines biomarkers and surrogates. I don't know the equivalent at EMA and what they have. But I'm wondering why it's clear that in the FDA language, my interpretation of it is that they are different, that it's important to distinguish because they're subsets. So I'm wondering, is that part of your question, is whether you go with the FDA framework?
Yes, we could go with the FDA framework, but I think that to date, most of what we've done is, most of the discussion here at OMERACT has been around it being a biomarker, and now we're trying to transition it to that surrogate.
Right. And so yes, so then surrogates are biomarkers, but not every biomarker is a surrogate.
That's right.
Exactly.
Okay. So it still might be important if you're trying to communicate with some of those organizations that you use the language that would make them
understand.
Make it understand easy to communicate. We realize this is a biomarker and we're trying to move it to surrogate status.
Yeah.
This is Tahina. I was also wondering about the FDA framework, because clearly the FDA considers serum urate a surrogate marker, and also listening to Ken and the issues regarding BMD and osteoporotic fractures. I've not personally reviewed the history of how serum urate came to be recognized as a surrogate marker by the FDA. Last year we had a meeting with the FDA regarding OA outcomes, and the FDA used serum urate as the kind of textbook example for a surrogate marker, but didn't sort of go into what was the evidence that they used to demonstrate that nice pathway that Robin outlined. So I don't know if, what data they used, or if that framework would be useful in framing this work itself.
Very informative. I listen to what you said.
I agree, Tahina, and we we have tried and been promised that people would help us get that data so that we could see how that was worked, but that hasn't been forthcoming. So we've not been able to access from the FDA or from the people who have said they would support us to do that, to get that information, because that would be incredibly useful.
I don't know if I have any further pull, but I can certainly reach out to Nikolai to see if he could help grease the wheels.
That would be very useful. Thank you.
Very useful, because many of the insights we have had is from D. Simon, who's very experienced with authorities. But even he gets, it can be difficult even for Lee to come up with the final reference to when and how the whole thing happened.
Lisa, should we have patients comment as well, now that we've had some discussion on this and some data sharing? I don't know if patients want to speak up.
Yeah, sure, happy. Actually, just a practical question, Lisa. Should I vote or not vote when you get to the voting bit?
You vote.
Sure. So I guess just to give some context, one of my main areas of research is in psychiatric genetics. And so I'm kind of sitting here going, if we had markers as good as serum urate in psychiatric genetics, we would be a long way further along. Yeah, I don't have the, I mean, you're the experts on serum urate and gout and so forth. I mean, again, I just probably reiterate what I said earlier. The feedback between serum urate, especially if it's being measured repeatedly, has been really useful. I mean, allopurinol was the first drug I've been on, a long-term drug, and it's really motivating to be able to see your urate drop. I mean, I completely agree with what Ken said earlier about, and something you all know, is how do you measure flares? And I recall going through some of Lisa's studies and her research nurse asking me all sorts of questions about general aches and pains and so on. And then reflecting on my own experience, my first gout episode was in 2007. I was aged 40-ish, something, 43, 42. And it was precipitated by a PhD celebration for one of my students, where I went to we went to a Belgian bar, drank quite a lot of really rich Belgian beer. I recall eating a stew that was baked in beer, and ate a lot of mussels. So it was precipitated by dietary excess, I guess. And it was a debilitating. I was on a bicycle. I found it very hard to ride home. I lived up a hill. And my ankle was, basically it was laid out for the remainder of the weekend, unable to move. And the first person I saw on Monday morning was Lisa, because she walked through my laboratory, and we kind of agreed it was probably gout. Thereafter, I didn't have too many other severe acute attacks. I'd have the occasional flare in fingers or ankle. Over the period when Christchurch had the mosque attacks in March last year, I recall having a rather chronic sort of set of flares which had gone on for several weeks, maybe even 2 months, and was making walking kind of difficult. Fortunately, we've got electric scooters in the city, and I was using them a fair bit to get around. But what I'm saying is that the flares that I've experienced have come in all shapes and sizes, so much so I didn't, often don't even recognize them. Be sitting on an airplane going, oh, my finger's a bit stiff. I wonder what that is. I also kept reasonably fit over through my life, I guess, and I still play volleyball, ski, and ride mountain bikes. I must say I often get sore toes after volleyball, which is always on a Thursday evening, and it's taken a long time to recognize that they're probably mild flares. I don't get them so much now on allopurinol. So, trying to measure flares, as I'm sure you all know, is, I guess, a dog's breakfast. So I don't know if those insights are useful, but I completely agree with the conversation from my point of relative inexpertise, at least in rheumatology. I do wonder if there are things like Mendelian randomization, the large UK biobank studies and so on, whether there are other ways of tackling this question of connecting serum urate with with flares, longitudinal studies, large GP, primary care health sets. I don't know. I'm sure you've thought about all these things. Probably enough from me. Thanks for the opportunity to talk.
Thanks, Martin. So if there's no other discussion, maybe we'll vote on this so that we can move on to our next question. So can we get the voting up?
Oh, I'm sorry to jump in. I'm David at PRP and CPPD, so I got in late because of other family issues just going on today. And quick question, just to summarize, so I can just vote maybe, is the biomarkers are the uric acid level, and I'm late, so can someone just, Dr. Jesse or Dr. Singh or Dr. Dalbeth, just summarize what are the surrogate markers that you're thinking should be take precedence over uric acid, following uric acid in gout patients that are the crux of this question?
So serum urate is the surrogate for the patient outcomes such as flares. So we would be measuring serum urate rather than measuring other things like flares.
So the biomarkers so I had it opposite. So yeah, okay. So clinical flare symptomatology from patients to their PCPs or rheumatologists compared with serum markers, just uric acid levels alone.
Yes.
Got it. Thank you.
Okay, so shall we vote on this question? Excellent. I think we've got agreement on that.
Thank you.
Thank you. So our second question then is, do you think there is sufficient evidence for serum, do you think there's sufficient evidence for serum urate to be a surrogate for gout flares? So maybe we could open the discussion here. Geraldine, would you like to start maybe?
I'm struggling with that because a gout flare is a gout flare. So your serum urate could be low or could be satisfactory or within therapeutic range for a year. And if you weren't getting prophylaxis with colchicine or some other agent, you could still be having flares. So I think they're different, but they're linked, if you know what I mean. So, I mean, I'm kind of new to the whole OMERACT concepts. So I don't know how that fits within the OMERACT filter. They're linked, but they're not the same. Do you know what I mean?
So I guess the question is, from what we've seen, do you think you could, you would be able to measure a serum urate, and if you were going to do a trial, you'd be happy to do a trial measuring serum urate,
Yes.
accepting that you didn't need to measure flares down the track. You'd be happy that if you got the serum urate to target, that would mean eventually the flares would
I would be happy that that would, yes, with that assumption. There's an assumption there, as shown by the Doherty study.
Yes, but also another way to pitch it would, and this is clearly controversial, for which I apologize, would we be happy with fast-tracking approval of a serum urate lowering drug without waiting for the flares to be reduced?
Yeah, I would, as long as it didn't have bad side effects.
Sure.
Or, you know, with the assumption that there was nothing bad that was unexpected, I would be happy, yeah, personally.
Lisa and others, I'm just kind of grappling with this kind of concept of how adherence and the time concept with serum urate can be incorporated here, because, you know, it's certainly possible to have a therapeutic that reduces serum urate, you know, at the time that the person takes it, but ultimately adherence is also going to be an issue. So I guess that what we're assuming is that the biomarker is the surrogate is a surrogate in the context of perfect adherence.
Yes, of course, as always.
So I guess that's just, that may not be the case, say, for something like BMD, for example, potentially, I guess. So, or I guess at least my concept is that BMD and, you know, a single measure of BMD or HbA1c has kind of longer implications than a single serum urate measure, where within a few days of stopping a therapy, the serum urate is up again. So I wonder if in the discussion that concept needs to be, or that assumption needs to be made clear.
Yes,
Nicola,
I think in a clinical trial, the serum urate is not measured just once, it's measured often. So it's not so much, you know, and to some degree there's monitoring of compliance as well. So, I mean, I look at it as hypertension. It's the same way. You know, we look at it, and if they're not compliant, their blood pressure is going to go up, and we're going to measure that. So, you know, and that would be measured in the context of a clinical trial. So I personally think that based on the flare data, there's sufficient evidence, but I have a more philosophical question. I think measuring flare is actually in the core domain set. So are you suggesting that we're going to not do this? And in reality, are people going to stop measuring flares just because they're measuring serum uric acid? So it's more the philosophical question of, in a clinical trial, people are probably still going to measure flares, even if you tell them that they don't have to. I don't know. I'm just asking, and maybe Ken or Jazz, I you could speak to that.
Nicola has raised two really interesting issues. The first is really efficacy versus effectiveness. Are we, you know, what is it? Normally clinical trials, traditional clinical trials, focus on efficacy. If we're thinking about more real-world pragmatic trials, and I agree that effectiveness is important. The second issue, though, is really a function of the therapeutic. And you used a comparison with BMD, which, you know, the drugs we use in osteoporosis have a peculiar longer-term effect in most cases. Now, some of them don't. And, you know, for example, denosumab may wear off very rapidly. And so I think the same would apply to flares, though, right? So if you have a drug that's affecting serum urate transiently and it's having a benefit on flares indirectly, presumably the benefits on flares would wear off over some period of time, you know, if you weren't using that drug. So I think there are confounding issues, but I'm not sure that it relates to the definition of a surrogate.
So Nidhi, I think Ken addressed most of the issues you brought up. I'll just add one minor thing to Ken's comment, which is I think people would measure both, but let's say you have a 3-month study or a 6-month study or a 4-month study, whereby you can show with a new agent that you have lowering of serum urate to target. But as a secondary outcome in the same study where you also measure flares, they either have not changed or have moved in the other direction, as we sometimes see with initial lowering of serum urate. So is that drug beneficial or harmful? And I think that if we knew that serum urate is a surrogate for gout flares in the long run, then you would say, yes, since it's a surrogate and the time is an issue, as Nicola brought up, that had the trial been run for 18 months, we would also see a benefit in flares, but the trial data being a 4-month data with a significant effect on serum urate and no effect or negative effect on gout flares, knowing this is a surrogate for gout flares, this is actually a positive trial. And I'm not suggesting that the FDA is going to change the way it looks at urate lowering agents, but if you had serum urate as a surrogate for gout flares in the long run, then that helps you perhaps sort that out in your mind by having that piece of evidence when 2 outcomes go in the opposite direction in a short-term trial.
Got it. That's a very good example. Thank you, Jazz.
I think another way of sorting this out in our minds is in the way that this question is pitched. When it asks, is there now sufficient evidence? Sufficient evidence for what purpose, or sufficient for what? And I can distinguish at least 4 situations. So clearly in clinical practice, the evidence is sufficient for clinicians to use urate as a surrogate for patient outcomes, because that's what we target when we treat patients. We know that getting their urate levels down in a sustained way will affect their patient-relevant outcome. It's already there already seems to be sufficient evidence for the FDA in terms of regulatory approvals for drugs. There may not be sufficient evidence for the statement to be correct in terms of a statistical framework like the BSE3 or the OMERACT framework or whatever. And there may not be sufficient evidence for study design because of the comments that have already been made about the need for or the usefulness of understanding patient experience as well as the biology in a clinical trial. So I think this is a very difficult question to answer because there are multiple contexts in which it could be potentially relevant.
It's Peter here. I'd like to second what Will has just said. Bloody fantastic, that framework. Please put that in the paper. That's exactly the discussion. But within OMERACT, we want something, the section in the OMERACT handbook, and we need a framework to do. We originally had that original discussions with Doug Altman way back, and we came up with some criteria, but they're almost impossible to fulfill. And so the uric acid fails. I don't believe it should. So I really think this is a great stimulus for us to go back and have that discussion around that framework. And given that people, as I'm hearing around the table, do believe it's okay for clinical, it's okay for FDA approval, heaven's sake, I mean, I can't think of a better example to go in the Cochrane handbook than uric acid. So I'm hoping we can find a way.
Thanks, Peter.
Before voting again, I'm sorry, jump in. Just two easy clinical questions for the rheumatologist, since that's not me. Do all flares, classic podagra or whatever the phrase is now for classic clinical gout flares, and the patient comes in the office, it's not even a televisit nowadays. Is that associated almost always in studies with higher levels of uric acid? I think the answer as a non-rheumatologist, yes. Is that correct?
No.
No.
No, not necessarily. Not at the time. Do you mean at the time?
Correct.
Yeah, no, because it's sometimes paradoxically when somebody presents with an acute episode, their urate can be low.
Yeah,
it's like a negative acute phase.
Right, I thought I heard you say that, and I was like,
Yeah.
Okay, so.
But so it's the in between attacks is the most relevant.
Right.
Mm-hmm.
And clinical effect for your drugs that we're talking about in quintiles of hyperuricemia. In other words, patients with, let's say it's 10, I know it's not 10, but let's say it's 10. So 10 to 12 have a certain bracket of clinical effects and gout attacks, whatever your surrogate is, clinical events, flares. And then 12 to 14 is higher, and 15 to, as you go up in brackets, of course, my teaching was that it's always higher with the highest uric acid levels over the average, aside from this negative acute phase reaction that you just talked about. So I think you have to have flares in there, just like Jazz said, but it's interesting. Help me answer my thought for voting.
So just a quick response to what Geraldine said. So first part, if you're, when patient comes in a flare, they already have had flares between half an hour to half a day, just because of the time of the day it occurs. And serum urate is usually presumably higher before and what led to the flare. It's just like cholesterol levels, when you have an MI, the lipid level goes down because there is change in physiology and where it goes. In terms of uric acid, crystals are coming out in the joint, and the serum level could be actually lower when you're into the flare at 6 hours, 12 hours, or 24 hours. So that's one part of what Geraldine was sort of trying to get back to you as in terms of being lower. But, likely or well known that probably before the flare started, the uric acids were persistently higher in people than people who don't get flares. The other part is, you know, quintiles or categories of serum urate. There have been some classic studies by Gutman and Yu from 60s and 70s, and also some observational data that both connect the levels of 10 to 12, 12 and higher with a very high certainty of developing gout, but also having frequent gout flares, and also in the incremental levels of proportion of people that have flare in the next year or two. So there is almost a linear relationship with both the risk of gout and the risk of flares with serum urate levels. But serum urate's being dynamic, just like blood pressure and lipid levels.
Just like you say about the linearity of cholesterol compared to 30 years ago, we didn't treat hyperlipidemia unless the serum cholesterol was over 300. Maybe that's 40 years ago. But in any case.
Exactly. That's a lovely analogy. Thank you.
So the point I would make, I think you answered the question that probably should be a 95 to 5 or 98 to 2. In other words, if you say uric acids are a surrogate solely for flares, I think the answer is yes, if you're trying to talk about efficacy of a drug, a uric or a suric or whatever your new pharmacology is with your new product. But you're still going to measure, like you said, secondary outcomes of flares, even if in a short-term trial of 3 months. Interesting.
Okay, well, we're out of time. So what we might do, because it's just past 7:30, what we might do is vote on this question now. Okay, that's
Wow.
great. I'm very surprised.
We are a biased crowd. That's good. Lisa and Jazz, will you wrap up, or do we have any last minute comments?
So I think that we are 3 minutes past time, and I know that there's probably a lot more discussion we could have had, but I really want to thank the patients, Lisa, Robin, Melanie, and all the SIG working team and people who participated today and previously in this work.